We are going to talk about Africa's vaccines challenge at a very pertinent moment, of course. The vaccine manufacturers say they have already manufactured around about 8 billion doses. There are predictions of 11 to 12 billion doses being manufactured by the end of 2021. But of course, they're mal-distributed in the world. The richer countries have too many. In the UK, for example, we have 9 doses per person. And of course, Africa is currently undersupplied. I heard yesterday that Malawi, for example, has run out of vaccines yesterday. So to discuss this, we've got a great panel. We have Dr. Ayode Oluwatombosan Alakija, who's the founder of the Nexus Hub, an innovative center in social development and emergency response unit in West Africa, the Sahel region, headquartered in Abuja, Nigeria. She's currently co-chair of the African Union of the African Vaccine Delivery Alliance for COVID, AVDA, and she serves on the Global Advisory Board of Women Lift Health and is chief strategist for Convince Africa. So we'll hear from her in a moment. We also have Dr. Fifa Rahman, who has over 12 years experience working in global health. She's currently the civil society representative on the WHO Access to COVID-19 Tools Accelerator, and she has a wealth of experience in infectious diseases. As well as her, we have Dr. Monique Wasuna, who's the Director for Drugs for Neglected Diseases Initiative in Africa, based in the regional office in Nairobi. She's, again, a physician who has a wealth of experience within infectious diseases, and she's currently a member of the Technical Working Group Science Standards and Regulation of the African CDC, as well as the African Vaccine Delivery Alliance. And to take us through all of these great talks, we have Dr. Lucy Kanya, who's an assistant professorial research fellow within my department. And I will hand over to her in a moment to essentially chair us through the rest of the session. She's currently a senior member of the team working on the African Health Observatory platform on health systems and policies within the department, and that's hosted within the WHO Regional Office for Africa. So those are our panelists in the chair, and I'll welcome them to our session as well. Before I hand over to Lucy, could I just say that we also want to have audience participation in the discussion today. And instead of a traditional Q&A at the end, we'd be keen to hear from you throughout the event. So do please interrupt our panelists so that they can react to your thoughts and questions in real time. To do this, use the Q&A feature at the bottom of your screen and join in the conversation, and we'll hopefully pick you up as your name and affiliation appear and your question appear. If you use social media, you can also follow the discussion through the hashtag LSE Africa Vaccine. And lastly, if you do want to re-listen to this, we'll put this up on our website as well for further access. Anyway, without further ado from me, let me hand over to Lucy to take you through to our panelists. Lucy, over to you.
Thank you. Thank you very much for the welcome and introduction to today's event, Professor Ali. So we are delighted to host these 3 experts and look forward to learning from their contributions today. As Ali said, we will reflect on the question of what vaccine and health technology equity means for global management of the pandemic and what challenges remain for health systems as vaccine rollout is operationalized. The panel will also explore the upstream and downstream access and distribution policies that are being employed to combat COVID-19 in the region, as well as asking the question as to how other essential health services, for example, routine immunization, do not suffer. So before we bring the panel, we would like to invite the audience to participate in this poll. So please take a minute to reflect and respond, and we will consider these results in discussing our first objective today. So as you do that, I would like to invite Dr. Alakija to set the ball rolling, to please give us an overview of the status of vaccine deployment in the African continent so far.
Thank you so much, Lucy. Thank you for having me. It's lovely to see both FIFA and Monique here, who are dearly, dearly beloved colleagues of mine in different fora. FIFA, I'm very excited to hear what the civil society has to say about this. You always bring such fire to a conversation. Your question about vaccine deployment in Africa, I can answer literally in 2 words: not enough. We have a continent of about 1.3 billion people, total population. I like to speak in absolute numbers because when you compare it to, somebody said to me the other day, the UK has deployed X number of vaccines, but Africa has deployed 40 million. Well, the UK is however many, 60 million people, and the whole of Africa is 1.3 billion. And so let's talk in absolute numbers. So 1.3 approximate billion people in Africa, and only about, so far, maybe less than 40 million vaccines actually deployed through the entire continent. As we all know, the rollout of vaccines has stalled. It's almost pretty much at a halt in most countries. I know Kenya, where Monique is sitting today, people are going to hospitals and being turned away because they can't get, and waiting for hours because they can't get a second dose. As Alistair said at the beginning, Malawi completely ran out of vaccines yesterday. Zambia also ran out of vaccines, I'm told, in the last few days. Uganda ran out of vaccines last week. Basically, there are no vaccines. So, I've been quoted as saying, what are the problems with Africa's rollout? I was asked once, I said, it's difficult to describe problems with something that is not happening. At the moment, because there are no vaccines, there is quite literally no rollout. India, conversely, we're told China has vaccinated over 1 billion people as of this weekend. 1 billion people, vaccines in arms as of this weekend. For Africa, we have less than 1% of the population has received 2 doses, and approximately perhaps 1 point something percent of the population have received 1 dose of a vaccine. But also, to be clear, we can't take Africa as an entire block. So Morocco, for instance, which has purchased Sinopharm vaccines from China, is really the biggest chunk of that 1%. Morocco, as one country, has vaccinated about 8 to 10 million people all on their own, or maybe today even more. So you have to look at it in Egypt are vaccinating more than the rest of Africa. If you come down to sub-Saharan Africa, you begin to see tens of thousands of vaccines deployed in some countries. So the situation is dire.
Thank you, Dr. Alakija. Very dire indeed, as you outlined there. Dr. FIFA, what would it take for Africa to vaccinate enough of its population to reach herd immunity then?
A lot of things, and it's kind of hard to answer in a short space of time, but I'm going to try. The first thing we need is to make sure that the rich countries end vaccine hoarding. As you heard what Alistair said just now, countries like the UK have 9 vaccines for every 1 person. And, this is all over the place. We've got 1.3 billion excess doses. The rich countries do not need this. They need to start dose sharing immediately, whether through the COVAX or through bilateral deals. They need to get it done ASAP. Mm-hmm. Another thing sort of that we need to focus on in terms of dose sharing is to eliminate the ability for donors to set geographical restrictions. And this is really problematic. It needs to be done equitably. At the moment, what this means is basically countries like France could say, okay, we're donating X million doses, but we're only going to give them to Francophone Africa, when other countries within Africa could be needing those more urgently at that time. Next, we need vaccine deployment plans to become public. A number of countries have put their vaccine deployment plans under the Official Secrets Act, and it needs to be public and available so that they can be critiqued. And good leadership means that you are open to being critiqued and open to having your plans improved. That's the next thing. The next thing we need is licensing transparency. And the reason why we need this is because we saw that through different deals, some countries, Uganda is the most famous example, getting vaccines at a much higher price than countries in Europe. That's really problematic. We need technology transfer so that companies in the global south can produce vaccines, and we need the TRIPS waiver, we need to sort out hesitancy, and we need to tackle the supply chain issues that are resulting in shortages of bioreactor bags and vials. So I hope that encapsulates most of the issues, and we need to tackle to make sure that Africa can reach herd immunity.
Wow, thank you, Dr. Fifa. You've actually moved already to one of our objectives, for the key objective for this session. But before we go into that, I just wanted to hear your reflections, Dr. Wasuna.
Thank you very much, Lucy and the organizers. It's nice to see the panelists, Dr. Fifa and my colleague and dear friend, Dr. Alakija. Thank you to the organizers and thank you very much. So for Africa to be able to vaccinate enough of its population to reach herd immunity, we really need to work on so many issues. You already heard from my two colleagues, Dr. Alakija and Dr. Fifa, what they thought, and really those are issues that are pertinent. So first of all, we have to continue to push for increased African leadership, commitment and political will from our heads of state and states and governments to prioritize the issue of COVID-19 vaccine acquisition and equitable distribution. As you might know, the African Union and Bureau of Heads of States and Governments acted swiftly when the pandemic hit us in March 2020, and they have done what is within their powers to acquire vaccines for their citizens. But I think they should do more. There are these hurdles of vaccine acquisition, there's hoarding of vaccines, but we're asking our leaders not to give up and do more. And you might also be aware that in August 2020, they endorsed the COVID-19 vaccine development and access strategy. This vaccine strategy for Africa aims to immunize at least 60% of the African population with vaccines that have been proven to be safe, efficacious, and create population immunity. Other leaders such as, so we should not stick just with our heads of state, but other leaders like community leaders, religious leaders, civil society organizations, they all have a critical leadership role to play in ensuring that more Africans get vaccinated. But of course, there are myths and misconceptions around COVID-19 vaccines, and this has really slowed down the uptake. And even as Dr. Lakija says, there's no rollout because there are no vaccines, and that is true. I also just want to highlight the fact that the African Vaccine Delivery Alliance, AVDA, which was created by the African Union to ensure vaccine shots gets into the arms of African communities. And the chair is none other than Dr. Kega Song, and the co-chair is here, Dr. Lakija, and who's our panelist today. They have constituted the membership of this alliance already, and work is ongoing. There are 5 thematic areas, and I am privileged, together with Tian from African Alliance, to be chairing the risk communication and community engagement thematic areas. And I'm getting to community engagement because this is where, as Africa, we can make an impact. We need to secure crisis communication and community engagement within our communities in the continent and working with many stakeholders. Evidence-based communication around efficacy, safety, and quality of vaccines should be communicated clearly early to the communities. For example, the issue of adverse events such as clots experienced when certain vaccines were given, this could have been communicated to communities as soon as it became known. Now we are faced with a new crisis of variants that could impact negatively on vaccine uptake. When there is communication, where there's a communication gap, it creates room for myths, rumors, and fear. African countries need to develop community engagement and risk communication plans, and AFDA is ready to work with their countries, ministers of health and other stakeholders, such as the civil society, to have country risk communication and community engagement plans. Inputs are also critical because it takes into account specific cultural values of communities. These are made by Africans for Africans. So countries should also build capacity to monitor COVID-19 variants, genotyping, improve diagnosis and treatment through clinical studies geared towards those areas. Right now, in one of the countries where we are working, only 1,000 cases are able to be, go through a diagnostic procedure for COVID-19, and out of that, 40% turn out to be positive. And this sample size is so skewed because these people are the ones that are going to the airport, and it's not a representative sample. So if we need to know the positivity rate to help us plan and assess vaccine impact. So we need information on COVID-19 infection also in children. We in Africa can learn a lot from high-income countries as much as they also can learn a lot from us to avoid rampage by the COVID-19 variants, such as the Delta variant. So we need to really build confidence in the communities regarding COVID-19 response, including vaccine uptake. Africa needs to strengthen their health system so that they are resilient enough to withstand added pressures from COVID-19 infection in terms of infrastructure, staff, ability to carry out immunizations, other immunizations as well as COVID-19. There's so much more that we need to do, and time is not in our hands, but I think together we can make it.
Indeed, together we can make it. Thank you. I'm saying indeed, together we can make it. Thank you. I think you already went into some of the issues that we're going to discuss in Objective 1 on the challenges and obstacles. And I just want to bring in Dr. FIFA at this point. So from your perspective, from where you sit in your position, what are some of these challenges, the pressing challenges and obstacles that we have faced as a continent?
I think, and I'm speaking from the ACT Accelerator perspective, because I sit there and I present to member states on what's happening in the ACT Accelerator. And I think the first sort of fundamental thing that we need to sort is to make sure that LMICs are not treated solely as beneficiaries, but they are treated as equal intellectual partners. And this is incredibly important because if you don't consult Africa, Asia, Latin America as equal intellectual partners, your priorities are going to be distorted. And I'm not precisely sure why it's so unnatural for certain people in global health to consult LMICs. But there are several examples on how it has distorted priorities already. It took one conversation for me to find out from a colleague in DRC that vaccine non-acceptors, so people who are hesitant, were 7 times more likely to cite distance to facilities as a key reason for not accepting the vaccine. And I can't remember how many times related to cost, but they also, non-acceptors were more likely to cite cost. It took me one conversation with a colleague from Liberia to find out that the ACT Accelerator had not sufficiently engaged community health workers that have been mobilized in the Ebola response to work on COVID-19 vaccines. It took me one conversation with another colleague to find out that a lot of community health workers who could be key allies and operators and implementers in the COVID vaccine response, that they're not salaried, that community health workers are not salaried. So it's, it's not a lot of extra work to consult and to treat LMICs as equal intellectual partners, but that sort of underlines all the decision making that is happening in the global COVID response. I also sort of want to talk about, a recent set of slides and that was circulated in the manufacturing task force of the ACT Accelerator last week. The date on the presentations is tomorrow, so I suspect they're going to be discussed tomorrow. But in 1 to 6 months, in the short term, they want to improve the input supply for the manufacturing of vaccines. Now, of course, there are massive shortages in the actual inputs you need to manufacture vaccines, like bioreactor bags, like vials and things like that. And it's horrifying to realize that Pfizer and Moderna have a whole load of inputs and supplies that they don't actually need. They have surplus. So the question is, why are these not being released to manufacturers who need them? So this is really, really concerning. And the COVAX says that it's going to deal with this in 1 to 6 months. But once again, there needs to be democratization of this knowledge so that people can feed in and make sure that the processes work well. In terms of access, we spoke about hoarding already. That needs to stop. But what needs to happen immediately also, while we have shortages of vaccines, as you heard, Malawi's out, Uganda's out of vaccines. What needs to happen as well is that people get access to rapid self-tests like we have in England, and I've got them right here. It's not fair that the global north gets them everywhere, but in Africa, because people are conservatively interpreting WHO guidelines, that they can't proactively manage risk. So that needs to happen as well, that people can self-test at home. A final point, and sorry for taking so much time, is on Biden's donations, right? Because everybody's like, Yahoo, we've got these Biden donations. But the problem about these Biden donations is that they are coming later in the year when so many Africans will already be dead, right? So there's a need for these countries to go beyond these sort of not highfalutin, but sort of like these announcements and find out, look, when is it coming? Because people are dying now and they need the vaccines now. Mm-hmm. So thanks. I'll end there, and I'd be keen to hear from Dr. Ayoade what you think about all of this and what we need to overcome these obstacles going forward. Thanks.
Yeah, thank you. Thank you so much. And I agree with you. I would really love to hear what Dr. Lakija has to say, on some of the, everything, but especially some of the key things that FIFA raises, the failure to engage with LMICs as equal intellectual partners, and the distorted priorities as a result of that. So I just, come in at this point and just share with us.
Thank you. Look, I love the fact that we're having a nice, rational conversation here, but we're not in a nice, rational moment. There's an urgency to this moment that we're in that I think we're underplaying. Already, Africa in the last week has seen over a 1,000-fold increase in cases, and that is considering the fact that we lack diagnostics. And also now we're finding out that we lack therapeutics, we have no oxygen. Africa is in trouble. We're right now going to the place where India was a month ago, and we're not on a slow incline, we're on a steep climb. We are losing our intellectual human capital in Africa. In Uganda last week, 9 doctors in a couple of days we saw announced died. Today, I see 4 or 5 legal practitioners, advocates in same Uganda have died. We have lost leaders. We have lost the Chief Justice of the country of Zambia. We have lost so many leaders just in the last 2 weeks. This is no time for us to sit around and be having nice conversations about, oh, please, we need them to give us vaccines. This is a time for African leadership to act, because otherwise we will die. As FIFA said, we will die in our hundreds of thousands. And not only will people die, but there will be no dignity in death, because people right now are begging for oxygen in hospitals. You're seeing trucks in places like Uganda with oxygen cylinders laden. You're seeing warnings going to to people's homes and to hospitals, because there are going to be explosions and fires because people are trying desperately to keep their relatives alive and they don't know how to handle the oxygen cylinders. We need vaccines now, not next month, not in 3 months' time, and not at the end of the year, and most certainly not in 2022. We need them now. I mean, I might sound cross. I'm incredibly cross and I'm exhausted. I am literally exhausted by the fact that I have been, and many of us have been saying the same thing over and over again for months. You know, Dr. FIFA talked about the ACT Accelerator. The last 2 COVAX meetings at the ACT Accelerator on vaccines, I was invited to chair. And this is where her point about equal sort of intellectual level playing field comes into play. This is not charity. And I have been put on record as saying that we have to stop treating this. People say to us in Africa that, oh, COVAX is a gift. No, it is not a gift. First of all. And number 2, it was not inclusive enough in its design. Because if you had asked me, Ayuade, when you were designing COVAX, if you had said to me, oh, we want to give you 20% of the vaccines that you need as a continent, because we think you're a young continent, you're only going to need 20%. I would have said to you, well, how about we change that language? How about you say that you're going to supplement the vaccines we need with 20%, but that you're going to work in partnership with us. And so we can tell you which vaccines we need. We can tell you which are our priorities and how that rollout will be. And because there has been, the global health system is broken. I have said this over and over again. The global health system is not delivering for anybody. It is a system that was set up after the Second World War in the 40s, the big multilateral system that was supposed to be the them and us, but the world has changed. It is not delivering for high-income countries because we see the 500,000 dead in over 600,000 now dead in the US, the hundreds of thousands dead in the UK, Brazil, 500,000 as of yesterday, India, at least 1 million, because that's an undercounting, and Africa now climbing. So it's not delivering for high-income countries, and it's not delivering for low and middle-income countries. Why? Because there is no inclusivity in the decision-making, because we are not at the table, because it is being done unto us, because it is being thought of as charity. Africa is the last playground in the world, to my mind, for this current architecture. It is the last playground because you can't do this anymore in India. You can't go to India and tell them what to do because they're making their own vaccines, which goes to FIFA's point about the manufacturing. You can't go to Latin America to a large extent because they are also, Cuba is doing incredible things with vaccines. I was just consulted on their offer now to share technology with others around the world. So they are doing incredible things in Latin America. So why is this being done in Africa? Monique just said about African leadership doing a good job, but our leadership needs to wake up and do more. African leadership needs to come to the party and ensure that we are equal partners because our lives matter too. And I mean, I don't think we understand the urgency of this moment. The numbers are climbing daily. When FIFA talks about the diagnostics, Nigeria is reporting 20 cases a day. Really? Really? In a country of 210 million people, 20 cases a day? That is my country, so nobody can say I'm knocking Nigeria, but that is not, it's not even credible, you know? So when the explosion comes from that country, for instance, of numbers and cases, the world is going to act shocked. We have to shift this global system. You know, health policy, I love the fact that we're doing this in this health policy department. I did my health policy in that building when I was starting my global health career, London School of Hygiene and Tropical Medicine. My health policy classes were there. And in those days, it was different. Because, you know, it was sadly 20 odd years ago, we were not necessarily seen as being part of that discussion. But that has to change today, like FIFA is saying. We have to shift the narrative and we have to become masters, mistresses in Africa of our own destiny. Vaccines must, Biden's announcement, really the G7 to my mind it was a disappointing moment. You know, people say, oh, it was generous. Biden and the United States of America was the only country that really came to play at that party. They came with their 500 million doses, yes, which is not enough. It's a drop in the ocean. You know, the world needs 10 billion doses. We need 10 billion doses. They managed to offer 870 million. So my thoughts on it is that we need urgency in this moment. We need Africans, not just Monique and FIFA and Yodi, who everybody must be sick of and tired of hearing my voice, because I'm sick and tired of hearing myself speak about this. We need people to stand up and say that our lives matter and that we need vaccines today. We can manufacture for next year because this thing is not over. The Delta variant is here and it's increasing exponentially in Africa, but we need vaccines now. However they're going to get them, wherever they're going to get them from, let them begin to ship into Africa today.
Wow. Thank you, Alakija. We will never get tired of hearing you say these things. So we'll invite you again. But before I wind up on this, Monique, do you have some reflection on what FIFA and Alakija have said on this objective?
In terms of the challenges and obstacles to vaccinating African population, they have spoken so well. They've taken words out of my mouth. I think they really hit the nail on the head. But I just need to say that, to repeat, because once you repeat something many times, it gets in. Just to repeat that one of the major obstacles is just the lack of adequate vaccine doses. We do not have doses. And imagine other people have, 9 times to vaccinate, as Alistair said, for their populations. So we need to get more doses, and as Yodi has said, we have to push our leaders even more. They're doing a good job. So what I just need to point out about the lack of doses, that there are some countries that don't even in Africa that don't even have any vaccine at all. They haven't received any. So what are we doing as a people of the world? Because now we have this Delta variant with us. And it is thriving in populations where people have not vaccinated themselves. So I think that our high-income country friends should not sit pretty, because we will keep generating more variants for their populations who are vaccinated. So are we achieving anything? Maybe not. I just want also to address the issue of vaccine hesitancy. It's another important consideration when it comes to talking about obstacles to vaccinating African population, and at least we can do something about this among our people. There's so many myths circulating, and we also don't have enough safety data to share with our communities. The issue of adverse events, we just hear from Europe and the US, of rare blood clots, but do we have data in Africa that people can say yes and associate with that data? Because if we have that data, we will try to remove this hesitancy from people and educate people even more in this. Also, I think that I have gone through this, but as I said, it's good sometimes to repeat. Really, misinformation and myths and are killing our people. Because as Africans, why would someone wake up one morning and decide that vaccine causes infertility, and everybody is talking about how these vaccines cause infertility? There's no data. And so we are scaring people from taking the vaccines. So we need to deal with this kind of misinformation, and that really causes hesitancy among our people. And the other thing is, and also, of course, the issue of microchips. For God's sake, the vaccine comes with chips and the devil and God knows what. We need to wake up. We are already dying as it were. We have to add salt to the injury. I think the other most important area is the issue of manufacturing capacity. This is a real challenge for Africa. We need to be able to address the issue of lack of vaccines. We need to make the vaccines ourselves. Right now, 99% of all the vaccines in Africa are imported, and only 1% are manufactured in Africa. And according to Africa CDC, Africa should aspire to manufacture at least 60% of the COVID-19 vaccines in Africa by 2040 and import only 40%, that would be really a good start. And the African Union, Africa CDC launched their partnership for African vaccine manufacturing to ensure Africa has access to vaccines and to protect its public health security. I think in the areas that they're going to cover is, really setting the agenda of this and coordination and being able to set up at least 5 regional vaccine production hubs in 15 years and be able to mobilize resources and financing partnerships. And this will be key because we need money to be able to, manufacture these vaccines within the continent. And also, of course, to strengthen the regional regulatory systems across the continent. We need to strengthen our own African medicines regulatory authority, and as well as transfer technology and task force, building the task force. So we need Africa to manufacture vaccines for Africa so that we can build confidence in the COVID-19 vaccination acceptance. I think those were my reflections, Lucy, and I take it back to you.
Thank you, Monique. I think Lalji wanted to come in. No, did I see your hand?
I have one quick comment there as my sister Monique talks about the fact that we need to counter vaccine hesitancy and vaccine confidence. And I think that, we have to be, as Africans, be very careful, because there is a tendency for people to sort of say, well, they don't want vaccines anyway, so why are we giving it to them? So we have to be really careful with that narrative. And there's one thing that I say all the time: there is no vaccine confidence without vaccine equity. And what do I mean by that? I mean that when the vaccines first were rolled out, say in the UK or in the US, people thought that there would be limited uptake. People wouldn't want them. Nobody was going to come and take vaccines. But FIFA made a very great point when she said, what's going on in DRC? For instance, we heard about South Sudan. I get on television for an interview, somebody says to me, oh, South Sudan is burning vaccines. Did anybody tell you that South Sudan only has at that point, only had one vaccination site for the entire country? So how are they supposed to roll out vaccines for the entire country when there's only one vaccination site? So there are specific, very context-specific issues. DRC, as FIFA said, there were specific issues to do with cost, to do with distance. In the US at the moment, we're doing a fabulous job with vaccine distribution. Everybody within 5 kilometers, I think it is, or 5 miles, whichever one it is they use at the moment, there is a vaccine. You can walk in anywhere and get a vaccine. When vaccines were made available to teenagers and 20-year-olds in the UK, of which I have a child in that range, my daughter ran from home. She sprinted to the nearest vaccine center that morning, first thing that morning, and said, give me a vaccine, because it was made available. Availability and accessibility are critical to vaccine confidence. So we can't place this label of Africans are hesitant when the West, the high-income countries, are throwing around these games, these geopolitical vaccine hunger games around, no, your vaccine is going to cause clots, your vaccine is going to do this. The hesitancy is not from us. The messaging that is coming out from the high-income countries, it's back to what I said about the global health system, does not benefit, is not working for the world, and it certainly is not benefiting us. It is set up for Africa to fail, to my mind, the current system, because if we're not included, then we will not be able to succeed. Over. Thanks.
Wow, that's a lot of information there, but thank you very much for those reflections, Dr. Lakija. We would now like to take some questions from the audience. I don't know if any questions have come through that, or if there are any questions that you'd like to respond to directly from what we have from the audience.
Do we have stuff from the audience?
Yeah.
Oh, where do I see it? See my text?
I can read one. Sorry. Firoz Kanagi asks, how do you evaluate the recent G7 commitments in supplying vaccines? What exactly is missing in your view? I think we've covered some of that, but you're welcome to contribute to that. And what should be good G7, G20 targets in your view?
I'll speak very quickly to the G20, G7 targets, and I mean, FIFA and Monique, I can maybe contribute to the others. I'll speak to the G20 because I was actually this for the G20 this year. I was appointed sort of a high-level expert advisor, whatever that means, because I'm not really an expert, and I'm not sure anybody's taking my advice. But you know, I was part of the group that put forth, sort of, you know, led by Professor Peter Piot of the London School of Hygiene and Tropical Medicine, who put together the recommendations for the G20. And the high-level recommendations were around also what the IPPR, the Independent Panel for Pandemic Preparedness, has been talking about, which is that the global health architecture needs to change, which is part of what I've said. The global health architecture needs to change. It needs to be more inclusive. There needs to be more LMIC, low-income country voices at the table. There needs to be more CSO representation at the table. You know, I remember in the days of HIV/AIDS, because I'm old enough, unfortunately, to remember what we did in 20-something years ago when we were fighting for HIV/AIDS equity. And what we spoke about in those days was people living with HIV/AIDS. Now, I said recently, I think at the last G20 meeting, I said, you know, we maybe need to start talking about people living with vaccine inequity or people living without vaccine equity. And we need to include those people in those conversations, because we have a saying a proverb in my language that any toba wo bata bata lo mo bitoti in town, let's say it is the person who's wearing the shoe who knows where the shoe is pinching. If you don't know whether my shoe is pinching, you cannot tell me how to adjust my shoe. You cannot tell me which size shoe I can get. I'm the only one who can tell you which size shoe I need. And that is what G20 needs to do. G20 needs to become more inclusive. The G7 commitments, I have already said, it was disappointing. You know, Alistair said at the beginning, UK 9 doses per person. Canada has 10 doses per person. US has about 5 doses per person. And they are so far ahead of us in the queue, because we're not also saying, and I want to make this point very strongly, because people have, you know, somebody watched me on television, I think on Newsnight or something, a couple of BBC a few weeks ago, and somebody actually had the gall to ring me and say to me that, you know, Yodi, you might want to take off your pearls and your gold jewelry before you get on television to beg for vaccines for Africa. So that is why today I'm wearing double pearls and more gold, because, you know, you cannot put the poverty thing on us. We're not begging you for vaccines. Vaccines are not a gift. It is a global good. It is a global public good. But also, as Monique has said, Africa is prepared to pay for vaccines. It is a matter of, let me enter the shop so that I can actually buy the good. You're not letting me through the door of the shop, and what is inside the shop? You have taken all of it. Then I say I want to make my own, and you say, no, I'm not going to let you have the permission to make your own. So we're not out with our begging bowl. We're saying we want partnership, not charity. And this is where G7 and G20 need to shift their thinking from that charity model, the old model, into the partnership model, and show that we are truly working hand in hand together.
Mm-hmm. Thank you, Dr. Lakija. Very interesting. So, and good. Well done for wearing your pulse and everything today. Question here for, well, a broad one, and I'll combine 2 questions. Why is AstraZeneca being sent to Africa when even the UK is rethinking its use? And think, well, as you answer this one, whoever is taking this one, think about the issue on vaccine hesitancy as one of the fueling factors, as you have said, is information coming out about the AstraZeneca vaccine. I don't know who wants to take this one.
I think I can give a short answer to that. And I also kind of wanted to feed in on a couple of other questions as well, if that's okay. Mm-hmm. Lots and lots, millions of people have received the AstraZeneca vaccine. And the risk of blood clots is much lower than birth control. And lots of us are on birth control. I think we need to think about the mess here, and we need to balance it with dying. And blood clots are higher. The risk of blood clots is higher if you get COVID, right? So we need to really sort of have a think about the risks that have been communicated, and the fact that the risk of blood clots is far, far lower with the actual vaccine than with actually getting COVID. So yes, while I agree that Africa should be able to choose its vaccines, I think we need to think about the evidence more clearly. On the G20, one of the things I was consulted on it, and I totally echo everything Dr. Ayoade said, because it's insane. This global health architecture is insane. I attended a C20 meeting, which is the civil society discussions up to the G20 declaration. And in this declaration, we were asked to review the declaration and the feedback. It said it would create a blueprint for future pandemics, right?
Yeah.
And I was like looking through the Zoom participants list, and I was like, where are the Black and brown people? Am I the only brown person on this call? And then I was like, oh, okay, there's a Black person, there's a Black person. So there were 4 Black and brown people on this call to create a declaration for blueprints for future pandemics. So how are they going to get their priorities right if they're going to create this blueprint with only the input of 4 Black and brown people? And obviously there was other discussions as well, but civil society itself is not diverse, and it's kind of really crazy that exists. So definitely an issue of global just global health architecture being completely bonkers. And I wanted to talk to Peter Owiti's question as well on the CTAP. Now, CTAP is, of course, a voluntary mechanism where, you can, manufacturers, if they want to, they can share their IP, right? And it's not been very popular. And it's because people are pandemic profiteering. It's funny that people think that appealing to the goodwill of pharmaceutical companies to deposit their IP to help save the world is something that will work. It's not going to work, and it's sad, but it's one of the things and one of the reasons why we need a TRIPS waiver. Thanks.
Okay.
Maybe Lucy,
Yeah.
can I just say one small thing?
Yeah.
So I agree with what the other 2 panelists have said, but I just want to talk about the issue of UK is not giving their people, they're moving away from AstraZeneca vaccine, and it's being pushed to us. I think that we have to look at it like in a positive way. Kenya, for example, participated in AstraZeneca clinical trials, and we were able to collect information in terms of adverse events, in terms of everything. So made a contribution. So I think that on the strength of Africa participation and having our communities participate in this clinical trial, it gives us a strength of believing in the data because our communities participated. So I think if there's data to dispute the issue of certain adverse events, fine, but I think we can't just move away because UK is moving away, and therefore, but what other choice do we have anyway? I think we have to weigh between life and death. Yeah,
wow.
That's what I wanted to say.
Oh, thank you. No, thank you both. And I can see many other questions from the audience here, which I think if we have time, we'll come back to, or we can try and respond to some of this directly on chat. I'm just saying this in the interest of time because I would really want us to cover the next objective. So let's now move to a discussion on regional coordination initiatives, whose aim was and still remains to more effectively ensure population-wide equity. Many of these existed before and have now either been reorganized specifically to address the pandemic, but we also have some new ones. So how effectively have these worked to ensure population-wide equity in the response in Africa? And I will start with you, Dr. Lakija. Seeing that the African Union has been at the center of coordinating vaccine-related efforts in the continent. Do you want to share something of what is going on in the region, or what your thoughts are, your reflections on these coordination activities in the region, not just from the AU, but all these other regional bodies that are engaged in coordination?
Thank you, Lucy. I think coordination is absolutely critical, and we have seen in this pandemic what leadership at continental and regional level can do, and what regional coordination can do. I think Monique referred to that earlier on as she spoke, so I'm not going to go into too much detail. You know, she speaks about ABDA, which I co-chair, which she also, you know, is a lead on one of the thematic groups on risk communications and community engagement, together with Tian Johnson of the African Alliance. There's a logistics group. We're all working together for the continent, because, you know, it's our voices together that will bring an end to this. We can't do it individually. It is more the global and the versus regional coordination that is really, I think, in this moment, the key. Because Africa has dealt before with Ebola. We've dealt with various crises. And I often pose the question that, had this crisis started in Africa, you know, had it started in, you know, Nairobi or Johannesburg, had that been where this was identified, it would have been dealt with very differently. The world would have been afraid that the African continent was going to spread this disease to their shores, and therefore they would have come in numbers to assist. But to my mind, because it started away from us, and because it was imported, obviously, you know, from other parts of the world into Africa, there was almost a sense, and I don't say this, that this was being done with any malice. It's more a sense of self-preservation, enlightened, almost self-interest, as it were, that it was better for the world to sort of believe that Africa was not truly having a pandemic, even though we know that that is, from science perspective, just not possible. It was almost better to look, let it be quiet over there, because at that point, remember, we didn't know about variants. It is only now that people are learning about the Delta variant, and they realize that, you know, what concerns the nose also concerns the eyes, and therefore that nobody lives in a vacuum, and that it could come back and bite everybody in the back. Eventually, that there is now concern with what is going on the continent. So regional coordination is important, but we've seen that without the leadership of Dr. John Nkengasong and Africa CDC has been amazing. You know, some of our African leaders, South Africa, in their chairing of the Africa Union Commission last year, did an incredible job in pushing this forward. And South Africa now co-chairs the ACT Accelerator together with Norway. However, without equal partnership, we go back to this thing that FIFA referred to, that I keep referring to, without equal partnership, without my voice being equal to you know, Sir whoever or Professor whoever's voice who comes out of the UK, or Peter's voice who comes out of the US, it's going to make no difference. We can shout as much as we want on Africa. I see a question in here about the resources. Look, resources are available for the world. There is enough if people are not greedy for the world to go around. We simply need to coordinate properly and work in partnership. So yes, African bodies like the Africa Union can help to coordinate and bring us all together. It is by working together that we've managed to acquire the 400 million, at least options for 400 million Johnson & Johnson vaccines to purchase, which are probably going to be the first vaccines we see on the continent. Because right now, as I'm looking from my co-chair role, I don't see in sight any vaccines coming onto our continent in the next 6 weeks, apart from emergency supplies that somebody might say, okay, let me lend Uganda 150,000 doses that was supposed to go to another country. There are no vaccines. So it is only African coordination that is bringing vaccines to us at the moment. But with global and regional coordination together, we will be able to see much more progress, not just for this pandemic, but also to prevent future pandemics and to ensure that the health security, which is where we are, the health security of our continent is assured, and that health justice is achieved for all. FIFA is chomping at the bit. I'm going to hand over to her.
Thanks so much. I was trying to answer the questions in the chat, but absolutely. So you know, this idea of not having Africans at the table is really important, and I want to refer to something that's coming out in the slides tomorrow that will be shared with the manufacturing task force. And they talk about this effort to establish a baseline of information on manufacturing, and the people leading that are Gavi, CEPI, Gates Foundation, and all of the names on the list that are gathering this information about manufacturing in Africa are all white male global north. You know, it's appalling. It's the situation where it's racist. And I know we've been trying to dodge that word, and lots of people want to dodge that word for some reason, but it's quite clear for some reason that people are not valuing the intellectual input of people from LMICs, and these are Black and brown people. Establishing the baseline of knowledge and manufacturing requires African knowledge. You cannot do that properly without African knowledge. So that's sort of the first thing. And that's sort of the first hole in coordination, right? They've got this plan, okay, we're going to work on manufacturing for Africa, but let's not put any African knowledge in it, or let's put the leaders of the global health agencies on it, but not make that African knowledge visible. It's going to fail if it continues the way it does. Mm-hmm. The next thing is that the manufacturing task force within the ACT Accelerator has three work streams. Work stream 1 is to tackle inputs, right? Shortages of all these supplies to make vaccines. Work stream 2 is for what is it? I think it's to tackle manufacturing, to scale up manufacturing in Africa, right? And IFPMA, which is the International Federation of Pharmaceutical Manufacturers, is featured prominently within those two work streams. Now, you know, we're not going to achieve equity for Africa when pharma is front and center within those two groups. Now, nobody's denying that you need some collaboration and cooperation with the private sector to get these vaccines through. But to have them, you know, front and center in working groups that are supposed to deliver equitable access to vaccines is just so not on. So, you know, it's so problematic. The next thing that's needed in the ACT Accelerator is for a joint open discussion between the ACT Accelerator, the Africa CDC, and the African Union, and member states. The idea that this joint discussion has not happened and we're 1 year into the pandemic is insane. Now, this sounds like I'm just going on and on and on about what is insane and what is like not working, but it's true. We need a joint discussion. We need a closed discussion. We need an open discussion with all the arms to make sure that we're reaching the right priorities. So, and we need to tackle health systems challenges. And speaking from an ACT Accelerator's perspective, the ACT Accelerator has the diagnostics pillar, the therapeutics pillar, the vaccines pillar, which houses the COVAX, and the health systems connector. Now, the health systems connector has not sat for months. And that's appalling. The idea, and of course, you know, the World Bank is saying it's doing all this health system stuff separately, but you can't deliver the vaccines or that therapeutics and the vaccines in an equitable way if you're not aware of sort of health systems challenges. And we've got the health workforce being decimated in countries. We've got masses of community health workers who are not paid, you know, and we've got water, sanitation, electricity issues that we need to sort to make sure that we solve all the sort of health system challenges. And the idea that the working groups have not sat in the health systems connector for a very long time is so problematic. So everyone who works on health systems, UNICEF, Gates Foundation, World Bank, and you know, this whole idea that, oh, they don't have enough capacity on health systems, that's ridiculous. The heads of health systems in Nigeria, in Zimbabwe, and all of these places, they probably went to the same Harvard School of Public Health that you know, the Gates Foundation people went to. They know what they need. The idea is to learn from them and to deliver health system services that can actually help bolster the response. So massive coordination issues with the ACT Accelerator and in capitalizing and making an equal partnership with Africa. Thanks.
Wow. Thank you very much, Dr. Fifa and Dr. Lalji on that one. So we have focused so far a lot on vaccines, but we all know that vaccines are just one strand in the toolkit. Research is also very instrumental for the long-term strengthening of the health response. So Dr. Wasuna, Monique, do you want to share with us what you're doing or what some of the regional research efforts around the COVID vaccine and such initiatives as well?
Thank you very much, Lucy. But maybe before I get into that, I just want to really echo what Dr. FIFA and Dr. Yade are saying in terms of coordination. And I think that we just need to emphasize the issue of equal partnerships. That is so key in the coordination, and that we should not leave Africa behind. We should be equal partners, because no one is safe until we are all safe. Coordination is critical, especially now when we are faced with the Delta virus, which is 60% more infectious and has increased its ability to cause serious illness. We need to really have coordination under our fist. Thank you. We'll move on to your next question. So thank you, Lucy. Research is critical in helping us shape the long-term strengthening of the health response to this pandemic. Besides vaccine efficacy and safety research, we actually need to carry out research in the areas of diagnostics and treatments that would help us contribute to controlling the COVID-19 pandemic. As we are already witnessing, this virus is very, very smart indeed. It's changing itself rapidly in an attempt to survive. So we must be a step ahead of this virus. And this is where research becomes critical for the continent, because there could be a lot of diversity and there could be a lot of quick answers that we can get to some of the prevailing questions. We should not, I repeat again, and we cannot sit and expect to extrapolate results from the high-income countries to Africa, because it could be a completely different picture in Africa. So we must, Africa must set its own research priorities, and African researchers must take leadership in carrying out research activities. This will bring trust among our communities. The African Academy of Sciences, the African Union, Africa CDC, WHO, World Health Organization, and other stakeholders have already done this together with the African scientists. And I think this needs to be operationalized. So I would like now to take time to tell you about DNDi, which is a not-for-profit drug research and development organization, and it partners, that is partnering with low middle income countries, especially in Africa, and where we have spent over 17 years doing clinical research and also innovating on neglected diseases. But now we using our experience that we've collected, because we work in the middle of nowhere sometimes in some of the countries where we are. So we collected experience of doing clinical research in these very, very difficult areas. And so we bring that to the table during COVID. And so the African Clinical Research Consortium, or the ANTICOV Consortium, was created. This is a group of 26 partners, including leading African research institutions and international health organizations, that was created and is being coordinated by DNDi in conducting the largest clinical trial in Africa, to be precise, in 13 African countries, in identifying the early COVID-19 treatments and that could prevent progression of mild and moderate COVID-19 to severe disease. This could complement the use of vaccines in trying to tackle the pandemic. So one might ask, why do we need clinical trials in low-middle income countries, and more specifically in Africa? We need these clinical trials because to date, most trials are taking place in high-income countries, and very few trials are planned in Africa and other low-middle income countries. And remember what I said, you can't extrapolate that data to Africa, the other low-middle income countries, because there could be differences. So as of May the 6th, of the almost 2,000 registered clinical trials, only a dozen involve sub-Saharan African countries, and most of them are not yet active. A lot of these trials are too small to be conclusive. So we need COVID-19 trials to be large, well-designed, adequately powered, so that it can generate evidence that will inform policy on treatment of COVID-19 in the region, in Africa. There are limited hospital beds and intensive care capacity, and therefore there's need to prevent mild to moderate cases becoming severe. Early treatment is needed, excuse me, so that we can limit the need for intensive care. And I think you've seen in the media what's happening in other countries, also in Africa, the need for ICU is becoming critical. So we call this big trial of 13 African countries that are involved in the COVID-19 treatment, the anti-COV clinical trial. This is a very large, well-documented, well-conducted clinical trials in Africa, and because we urgently need to support the development of guidelines, as I said, on prevention and clinical management in resource-constrained settings. We therefore need effective therapies for mild to moderate COVID-19 patients, and therefore if we succeed, we would then be able to recommend this for adoption within countries in Africa. And anti-COV really aims to assess the efficacy and the safety of different treatment regimens in mild COVID-19 patients with a focus on resource-constrained environments. And the expected output is that we'll have data, as I said, and we'll then be able to treat this virus in its early stages by developing strategies, because we'll have some kind of treatments that work. And the outcome, of course, would be that we will rapidly provide evidence for policy design in COVID-19 response. We have started this clinical trial. Some countries out of the 13 have already started recruiting, and we will keep everyone informed of what we eventually find. But quickly, just if you allow me, Lucy, I know I'm talking too much. I can also talk about the COVID-19 Clinical Research Coalition, which is a global community of change makers working to fast track research that will provide evidence on COVID-19 prevention, diagnosis, and case management in resource-limited settings. This is the evidence that is needed to guide policies and practices. The coalition currently has 224 institutional members with 408 representatives from 65 countries, and 35% are from Africa. This coalition was launched in March, 31st of March, 2020. So really the aim of this research coalition, and I ask people to Google and to join, is really to establish a vibrant dialogue within the network of researchers and allied institutions around the world. And collectively, we can just facilitate and accelerate research that's adapted for resource-limited settings. And we then will bring answers to all the questions that we want through this collaboration. And we then facilitate and prompt sharing of findings, sharing of data, and learning of young people. We need to mentor them, and so that they can also be involved in this kind of research. But the bottom line is we will need evidence so that we can have change in policy or direction for policy. So I think that would be my contribution for research. So
thank you, and very important.
My colleagues can Dr. Ayode and Dr. FIFA, you can feel free to contribute to this discussion.
Yeah. No, thank you already very much, Monique, because we all know the importance of health research systems. And one of the takeaways from this, we hope, is that there will be strengthened national health research systems across the continent. I think I just want to jump onto the final objective, and then we'll come back to all the questions and come back to any final reflections from all of you. And this on looking ahead to opportunities, lessons learned, and best practices. Someone once said that a crisis is a terrible thing to waste, and we shouldn't waste this crisis. So this, I mean, we all know it continues to be a health, economic, and livelihoods crisis, as we have already said. We have a final poll, which I will ask my colleagues to share, and this can keep running even as we continue with the discussions and the questions. I'll just like to ask you to take a moment and 1 minute and respond to this one. And the question is, how confident are you that African governments and the global community are adequately addressing Africa's vaccine challenge? And as we do that, so just thinking back to the beginning of this pandemic and where we are now, what are the opportunities, lessons learned, and best practices that the region could tap to? And just related to this, how might the rest of the world, particularly the global north, support the pathway to vaccinating Africa's population to the point of herd immunity or beyond, if possible? And I will ask Dr. FIFA to start us off on this one.
Thanks so much, Lucy. So I want to start with the TRIPS waiver. And I know that lots of people, and I just debated sort of a massive jerk, if I can, am I allowed to say it, who was against the TRIPS waiver for Africa. And he said, you don't need the TRIPS waiver, because, Africa doesn't have the capacity to produce vaccines, all this sort of horrible racist arguments. But you can't make an apple pie without the crust, right? You need the TRIPS waiver to make sure that you can go to the next step, which is tech transfer, right? Mm-hmm. And during the vaccine manufacturing conference, you heard so many people talk about how we need a new TRIPS for Africa, and that is completely correct. There needs to be an IP regime that works for Africa, and there's so many examples from the developed world where they didn't have patents back in the day, and what happened was they wanted to innovate and innovate and innovate. So they disabled the patents, or they didn't have patent system. And there are examples from Japan on this, and of course Japan is one of the most industrialized countries in the world. This happened in the United States as well. So obviously Africa has to make a decision for itself on the new IP regime. I think it's important as well to point out, when France or Germany and all these countries say, oh, we are all for global solidarity, we are all, all these words around global solidarity, but at the same time, a number of these countries are opposing the TRIPS waiver. And negotiations are of course ongoing. And there is a major barrier in this note, communication note, you can Google it, that the European Commission released, and I suspect is going to be discussed at the TRIPS Council in these ongoing negotiations. So this note that they released on 4th June, it has 3 things that it mentions as more important for the pandemic and vaccine manufacturing. Number 1, getting rid of the export restrictions on the supplies. So this means like VAT, value-added tax for vials and things like that. Get rid of the export restrictions. The next is we need to expand production of vaccines, which is okay, everybody knows that. And the next is compulsory licenses. Now, compulsory licenses is the tool that you can use to override a patent. right? And it's been done in Malaysia with the Hep C drug, and they got generic hepatitis C drugs, and you get cheap and affordable access. And it's been done in a number of other countries, including South Africa and India, right? Now, compulsory licensing is not a solution to this pandemic. This is because compulsory licensing needs to be done country by country, product by product. So if you issue compulsory licensing for the Pfizer vaccine, it's just the Pfizer vaccine, and you still you need compulsory licenses for multiple other products. So the idea that the European Commission is promoting compulsory licensing as a solution to a pandemic that is taking hundreds and thousands and millions of Africans now is just, they must think we're stupid, So this is something that obviously needs to be defeated. And I don't think we should give any heed to this European Commission note that they are trying to project as necessary to discuss on the TRIPS waiver. We should just dismiss it. I also want to talk about sort of new approaches to public investment where, this is obviously still being discussed, but there needs to be a different way to run the global health system. And right now, the donor-led system, of France and Germany and the UK and the United States, it just creates inequity. So I know we're running out of time, but we also need to capitalize on all these health systems plans that have come out, including the USAID 2030 plan on health systems. Without tackling that, we're not going to be able to tackle herd immunity in Africa. And keen on your thoughts as well, Dr. Ayoade. Thanks.
Thanks. Dr. Lakija, just jump in on this.
Thanks, FIFA, and thanks, Lucy and Monique. Look, there is an opportunity in this crisis. It is a critical moment for the continent, a critical moment for the world. And yes, there is a lot of doom and gloom. There are no vaccines. People are literally dying. We're seeing exponential rise in cases in Africa. However, the things that I would say we need to start doing is, number one, there's a lot of the pace, the sort of slow pace at which we're working at this really concerns me. We're treating this like a development issue. We're treating this like, agencies, the researchers, scientists, Africa, we're treating this like, we're eradicating polio. No, it's a pandemic and it is killing people within a few days. It's not even like AIDS that was taking time. The people would be sick for years and then die. This is killing people immediately. And therefore, we need to stop treating it like a development issue. We need to start treating it like the global humanitarian crisis that it is. And to that end, one of my recommendations is that global health leadership and this whole global health infrastructure needs to adapt to embrace that. Some of the leaders of some of the organizations that Dr. FIFA mentioned just now, they're all development people. They've all worked in development all their lives. They're not crisis people. They haven't worked in crisis situations. We need to bring in the crisis managers. We need to bring in the firefighters. When you have a fire, you don't bring in the plumber to fix your pipes. You bring in the firefighter with the fire hose. So who are the firefighters? Who are our global health leaders from the global south, from wherever, the global north, who understand how to fight a fire, who understand how to deal with a global humanitarian crisis? So that, for me, is one of my recommendations to FIFA and the CSOs as they're talking forward, because yes, she mentioned who heads Gavi, who heads this, that, and the other. It's not so much just who they are, but it is what their expertise is. This is a situation that nobody has ever faced before. This is a once in 100-year event, which requires a once in 100-year response. And as FIFA has heard me say several times before, a once in 100-year level of global cooperation and solidarity. So that, for me, is one opportunity within this crisis, that we can reshape global health infrastructure and architecture so that it is more adaptive to the situation we find ourselves in, because this will not be the last pandemic. The other thing is that in the HIV/AIDS era, over 20 years ago, we fought and fought and fought for over 10 years to get affordable drugs to people. And in the meantime, and again, it was Africa, and in the meantime, millions of people died. And so we have that experience, and the opportunity here is to lean on that experience and ensure that we're not working for another 10 years because one of the questions we didn't answer that you asked at the very beginning, how long will it take to achieve herd immunity? At current rates, never, but with some vaccines trickling in, the best estimates is 57 years. 57 years. You want to be walking around with masks? Well, some of us will not be here in 57 years, but with social distancing, not being able to hug your friends and family for the next even 10 years, even 5 years, it is affecting the very fabric of who we are, the very fabric of it's affecting our culture. It is shifting and changing our culture and who we are as a people. So the opportunity there is, let us lean back to AIDS, what worked and who helped us get out of that. I'm not going to go into trips and what have you, because FIFA has dealt with that adequately. But I do want to address this issue of tokenism and racism that FIFA has also mentioned. And I think this is an opportunity again to bring that to the top of the table, to bring the fact that my truth, I have said before that, I am the one who knows where the shoe is pinching my foot. If my truth cannot be explained by somebody from the global north, it cannot be explained from somebody who is not sitting in where I sit and dealing with the issues that Monique and Lucy and all the rest of us in the world fits. I mean, I was introduced as being on the board of Global Women Lift, which is bringing women to the top of global health. But the intersectionality of that as well, we also need to bring women from Africa to the head of global health. It can't just be that women from the global north are being pushed to the top, and we are tokenistically being included in conversations just so you can say, oh, well, we had a brown face in the meeting. Are you listening to my voice? Are you acting on what I say? Don't use me as a token to tick your boxes. But we want to have, I have another thing that I talk about getting a seat at the table or climbing on the table. And what I love so much about FIFA and her energy is the fact that you're a table shaker. I talk about climbing on top of that table. And now we not only climb on the table, but we shake it till it breaks. And then we make our own table, because this current system is not working for us. So for those of you who are at the LSE, for instance, LSHTM, students in health policy, my plea to you, the opportunity for you all in this crisis of what you're seeing is, your goal in life needs to not be to go and join WHO or join UNICEF. Your goal in life needs to build Africa's health system so that your grandparents and your parents and your children to come will live and not die. Because if we keep trying to build a system that was external to us and was in many ways built for a different world to the one we're in, we're never going to see health justice. Health justice is only going to come when we have strength and voice at the table. Like FIFA said, when Africa CDC is sitting face to face, equal eye to eye, not looking down on with Gavi, I've also argued with you, FIFA, that there should be a seat created on the Gavi board for the director of Africa CDC. So that, because we use 25% of the world's vaccines, COVID or no COVID. So why is it that if we're using a quarter, why don't we have a voice in how it's being done? Why is that being decided for me in Seattle or in New York? So the opportunity in this crisis is we need to seize the place and get a seat at that table and make sure that we shake it until our voices are heard and until we get what we need for health justice, not just for this pandemic, but to prevent future pandemics and to ensure that women, children and men in Africa attain their true potential. Over. Thank you.
Great words of wisdom there. Thank you very much. Dr. Wasuna, I think in just a minute and a half, if you don't mind, conclude for us.
Yeah, true, because my two sisters have really spoken from the heart, and I don't want to wipe away the wisdom that they have shared in this conference. I like the idea of, getting on top of the table, breaking it and making your own table. I mean, that has to be captured somewhere. It's really, really a good expression of what we in Africa should be able to do. But I just want to say that just pay tribute or pay my congratulatory messages to Africa CDC for the except for their very good coordination in terms of leading Africa in the fight against this pandemic. I think working together with the heads of governments, they've really been, in my own eyes, made strides and success. And I just want to say, well done, Dr. John Kengasong and your team. You are a true son of Africa, and as a mother, and I'm seeing hope that we'll get somewhere. So please don't tire, and work with the heads of state. We are behind you, and we will support you. So thank you very, very much. Also, I just want to say that this coordination that Africa CDC is doing, it really matters, and the African voice really matters. We have to have this voice, and we have to be where everybody is. So equal partnerships, again, for me, is key. Okay, in a very small way, our presidents, every time we have a spike, we get, you're locked down and there are restrictions, and the citizenry are not happy because, we have other illnesses, we have poverty, we have so many issues around us, and then to crown it all, this COVID. But then just to pray for understanding from the communities that, we are in this together, and we need everyone. Everyone has to play their part. If John has to succeed and other people, our presidents have to succeed, we the citizenry have to play our role. So I think that that's the lesson learned for me, that everybody has a role to play. But regarding the global north, I just want to say that really, I think we are happy for the little that is happening, and probably more that is coming. But the global north really needs to put its mouth where is what they are saying. Like, here we are trying to manufacture, we are trying to sort ourselves out. We need more vaccines, we need money, so we need help, yeah. But we are not going to sit and wait for the help. But so Africans, we also just need to rise, stand up, and fight, and contribute. Yeah, contribute your intellect, contribute your money, whatever it is. Let us contribute to the fight, fighting this pandemic. We will not get anywhere if we can't get resources. We need to get resources from within, and I think Africa, we are rich. We just need to put our money and prioritize where we put our money and our intellect. So let us avoid vaccine nationalism. Please, why should somebody be holding 10 times the number of vaccines for their citizens while we can't even get a first dose? We are just, left really to die. And I think it's not nice to just watch your friend dying while you swim in luxury and everything. I think let us just remember that we are in this together, and we need each other, and no one is safe until we are all safe. So thank you very much.
Thank you very much, Monique. Indeed, no one is safe until the last one of us is vaccinated. And thank you very much for the great takeaways as well. If we are not invited to this table, Dr. Alaki just says we climb on this table, invite ourselves and climb on it and shake it until it breaks and make our own table. But very important. I think we've run out of time. We have a few questions from the audience, which I suggest that we respond to, I think, directly, rather than give people the opportunity now. It's already past. But I just want to say thank you very much. It's been a great pleasure to have the opportunity for both me and I believe all of us in the audience to listen to our speakers today. Very great insights. Thank you to the audience too for making time to join us. We are really grateful that you could find time in your busy schedules to just join us for this 1.5 hours of some wisdom, words of wisdom from the key players, some of the key players in the vaccine discussion in the continent. We'd also like to thank the Firoz Lalji Institute for Africa, LSE's Global Health Initiative, and the Department of Health Policy Communications team for organizing and helping run this event this afternoon. From all of us at LSE, stay safe, and we hope to see you at one of our events again soon, be it virtually or in person. Thank you very, very much for your time. Thank you.
Thank you.
Thank you, everyone.